slow it down a little bit, but your stomach empties very rapidly. So you have to think to yourself, wow, I've been feeding them 50 cc's an hour in that continuous drip, and they have 8 hours and it's still sitting there. Or I haven't fed them through this NG tube for 4 hours and it's all still there. What's up with that, all right? So in that case, I'd put it to the side, and I'd call the physician. I'd stop the feeding or hold the feed and call the physician and ask what's going on. Okay, and say, do you want me to put it to suction because they're not absorbing? Something's changed about their condition. Do you want me to go ahead and replace it, but wait with my feeding and attempt it again in a few hours, recheck the residual? The research shows that 85% of the time a high residual is a lone event, meaning you probably could put it back, wait a couple hours, and refeed them, but you need a doctor's order for that because this is a doctor's ordered thing. And the new protocols that are coming, we need to get this for you so you can take it up to Adventist and get it going on, Nico. And that is an algorithm where the nurse is totally driving the boat and deciding. So you started tube feeding, and in 4 hours you check residual, and if it's okay, you double the feeding. And if it's not okay, you actually give them a drug to enhance motility, and in 4 hours you double it, because the whole new drive in nutrition should be feed them, feed them, feed them, keep them going, and so on. Okay, so let's say all is well. And you know what my experience is, and I'll see if Namiko bears this out. You know what my personal life experience with enteral feedings residual is? There's either almost nothing, there's 10 or 15 cc's, or there's hundreds. That's just my experience. It's either nothing or you got a problem. I had a student last quarter, and we were at a hospital and we were checking residual, and the standard of practice is you must do this every 4 hours, and before you're going to put something down that tube. So we'd done this all at 8 a.m. as a part of our head-to-toe physical assessment. You got a tube, I'm going to wonder about it straight up with your assessment. You got an IV, every piece of equipment you have, I'm checking with your assessment because I just said I was taking care of you. Jane Hook RN right after that, so on. So I would check all of this as a part of my morning assessment. And so we did all that and it was fine, and then I took the student in at noon and she was like, why, you just did that, why do we have to go through all that all again? Spike of fever, right? Drop your blood pressure. Feed some bacteria into your bloodstream, and peristalsis will grind to a halt, people. And people can change dramatically in a couple-hour period, and that's why we're watching them, okay? Give them narcotics and so on. Everything could change. So you are doing this every 4 hours. People who are on an automatic feeding pump, I like to only put the volume to be administered to 4-hour rate, because that way my slave reminds me if I space out, would you come beep, 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 beep? Oh gosh, that thing's bumping down in that room. And now I know, oh, that's right, I said that because I want to go back and check the residual, all right? If you don't have your watch or clock or something like that, that's how I recommend doing it. Where is the pump right here? Well, you wanna, thank you. So, the other thing I could have done was measure the tube from the insertion site to the end. That's what the other thing they're talking about doing is actually having numbers on them and so on, or actually a measuring tape, like take a paper measuring tape and go, yep, still 21 centimeters, all right? And that's how I know it hasn't moved or in place. Thanks. Oh yeah, this is how they were doing it. Okay. So now from a tube standpoint, I know I'm okay. My residual was fine, it's in place, I've got all that, I believe that it's all right. By the way, these are changed every how many? Every 24 hours, and so they put them at the bedside. There's a little plastic bag, and there's a date and time on it. And if yours has not been changed for 24 hours, or is no date and time for you to know it, you have to sling it and get away. And typically, the nurses' aides are kind enough to do this for you. They come through and change everybody's at the same time. But we function as nurses' aides in the first part of nursing school, so we don't mind helping out with that process. Now I have to move on to looking at my person's abdomen, right, and determining if it's safe and effective time to be able to feed them. So the first part of abdominal assessment is what? Inspection. So I look, and what am I looking for?
Any bulges?
That's right. I want to know if they're really distended, if they have this huge inflated-looking abdomen. I'm a little concerned, aren't I? All right, and what's the second part of auscultation? Where do I start from? The right lower quadrant, because I'm following the transverse colon, right? And I'm listening, and what am I hoping to hear?
High-pitched, gurgling, irregular.
Okay, and how often? Would I hear those?
5 to 30 times a minute.
5 to 30 times a minute. So it should be within a few seconds I hear something, am I right? Okay, I mean, if it's 5 times in a minute, within 10 seconds I should be hearing, right? But the average person is a lot more of that. So I listen along. And then I could be asking the patient, are you nauseated? Do you have any stomach pain? I certainly note if they were vomiting, that would be deeply concerning, all right? And then I could actually do light palpation, right, to see if I feel anything. What else do I want to know about their abdomen to know that it's okay to keep putting things down from the top? That's right. I want to make sure it's coming out the other side. So when did this person last have a bowel movement? One of the complications of tube feedings is diarrhea and or constipation. Diarrhea is more common because the solutions might be hypertonic as they're really calorically packed, and so it pulls water to the gut and increases stool elimination. And then, so I'd want to know if they're having diarrhea before I gave them that, because I'd want to call the doctor and get it switched.
You just
right?
ask the patient that?
Yeah, or I can look at the chart to see when they had their last bowel movement. Okay, so let's say this patient has been ordered to get a continuous drip enteral tube feeding. So here's a tube feeding pump. We had a great conversation the other day about whether or not you could use an IV pump or if you could hook the IV up there. Or, okay, these are single-use things. You couldn't put something through somebody's vein with this. You couldn't use a vein pump to feed a person. So this is an enteral feeding tube. It only has a feeding purpose. They're not interchangeable, an IV pump and an enteral pump. Does that make sense? Mm-hmm. But I actually don't care if it's short or fat or wide or blue or white or green, or if it has a cute name like kangaroo, or if they call it the giraffe. They're all going to have a similar feature. It's going to plug into electricity. All right. By the way, in a hospital, a white outlet is the normal outlet, but red outlets are hooked to the emergency generator. So if there was an earthquake or something happened in the hospital and power went out to the hospital, the lights would dim, and within a few seconds you hear a sound, you hear it kind of grinding up and the lights come on a very dim level, but this electricity is disempowered and only the red sockets work. So if you had something crucial like a breathing machine or IV pump and stuff, you want to make sure you put it in a red socket, all right? But when you turn it on, it has a microchip because it's a computer, and so what you're going to see is, see, it has AC. It also will go with battery as well if you keep it plugged in so it is charged. So when I see it come on, you see how it's check 888? Every piece of electrical equipment in a hospital will say 888. And if there's something wrong with it, it might start flashing something that's not customary. It might say error, ERR. Or it might say, funny kind of LED readouts, which is a hint to you. And all you would do is say, gee, this isn't working. So you take it down to the soiled equipment room. There's actually a tag there where you can mark it for the biomedical department to fix it, and you'd go get a new one, because we wouldn't use a piece of defective equipment on a patient. All right, and this one actually secures to the IV pump. It has a little, lock latch. You can do this. So I could take it off and hook it on the bed rail if patient was going to leave and I didn't want to roll the IV pole. I wouldn't suspend it on the trapeze over their head. Remember we talked about that falling on their head. All right, and it has a way, and they all do. They all look like, I don't care what the name is, short, fat, wide, blue, green, it doesn't really matter. It has a way to choose the volume that you're going to put in, all right? And so you can push the, volume clear, sorry. You can, volume to be delivered. So you would push a button. Is it going fast now?
Yeah.
Okay, to get to wherever you want it to be with this. All right, to choose that. And this volume will keep track of how much it's given the patient. And then, but you'd have to clear it. And I have to say, nurses don't rely on IV pumps to determine how much fluid has been delivered. They're usually counting it themselves by coming there. But you could do that. And this is where the volume to be delivered is where I like to set it up to grouch at me in 4 hours, because it will remind me. All right, so that could be ready to go. The tubing needs to be changed every